Thank you very much for making your time available to come and learn a little bit more about this program of outcomes research into the issues of the use of anticoagulant drugs to manage patients at risk of thromboembolic disease. I'm Ajay Kakkar, Professor of Surgery at University College in London and Director of the Thrombosis Research Institute in London. I'll be joined today on the panel by a group of experts from around the world who basically are also members of the steering committee of our Garfield research program. These I wanted to show you before I started speaking are my own disclosures. Although the Garfield program to date has primarily focused on the question of the burden of thromboembolic disease in patients with atrial fibrillation at risk of thromboembolic stroke, what we're going to be talking about this afternoon is, of course, some of the interesting insights and the unique methodologies that we have brought together for the Garfield atrial fibrillation program, but also start to put into context the problem of venous thromboembolism and how outcomes research in the area of venous thromboembolism, better understanding the burden of disease and the outcomes for patients over a long period of time, particularly after they've completed treatment for their acute events, might help us better improve clinical practice and the outcomes for our patients. And venous thromboembolism is the third commonest of the cardiovascular disorders after coronary artery disease and stroke in terms of its impact on mortality. There's been a large amount of epidemiological modelling in the past to help us better understand the full burden of venous thromboembolism. The reason the data is principally modelled is because venous thromboembolism is often failed to be diagnosed. Deep vein thrombosis in the legs can masquerade, as you will hear later, as a number of other conditions and is frequently missed. And pulmonary embolism, when blood clots break off from the leg veins and end up in the lungs, the potentially fatal manifestation of venous thromboembolism, is often not diagnosed, even as a cause of death, because patients frequently don't undergo autopsy when they die suddenly. And therefore, deaths that should be attributed to pulmonary embolism are frequently attributed to other causes, such as myocardial infarction or respiratory problems. And as a result of that, we estimate frequently the true burden of disease. But it's suggested amongst member states of the European Union that there are some 640,000 cases of symptomatic deep vein thrombosis and about 380,000 cases of pulmonary embolism. That the deaths associated with venous thromboembolic disease amount to just under 500,000 cases a year in the EU. In the United States, deaths associated with pulmonary embolism are estimated at something between 100 and 300,000 cases a year. But that burden of venous thrombosis, attending patients who have been confined to bed in hospital, and also spontaneous disease that occurs directly in the community, is probably underestimated. Now, one of the issues with regard to venous thromboembolism is not only understanding the burden of the acute disease. How do patients fare in terms of their clinical outcomes from the acute management of their thrombosis? Are we using interventions that have been evaluated in clinical trials appropriately in real-world clinical practice to achieve the maximum benefit for our patients? But also, do we really understand the full burden of disease? That is, not only the disease in the acute setting, the morbidity, pain, swelling in the legs, discomfort, breathlessness, associated, for instance, with pulmonary embolism and pain in the legs with deep vein thrombosis, the acute mortality, but the long-term manifestations of the disease, venous ulceration and the post-thrombotic syndrome in the leg, and pulmonary hypertension in the lungs. And my colleague, Dr. Jeff Weitz, is going to talk more about that in a moment. But there are many unanswered questions that we would like to address in the coming years as an academic and clinical community to ensure that we can achieve the same advances in the management of venous thromboembolism that we are now achieving for patients with thrombosis associated with either atrial fibrillation and thromboembolic stroke, or thrombosis in the coronary artery circulation associated with acute coronary syndromes and myocardial infarction. And so there are a number of questions that this type of research will identify by, and hopefully answer, by looking at patients not selected to participate in clinical trials, as is the case in randomized controlled trials, but by looking at unselected consecutive patients in the real-world setting and following them irrespective of the type of therapeutic intervention for longer periods than we would do normally, many years, as we have done in the GARFIELD-AF registry, to better understand how our patients fare and how we should most responsibly apply the innovations in clinical practice, and particularly anticoagulation, for the benefits of our patients. With that, I'm going to introduce Professor Jeff Weitz, who's Professor of Medicine at McMaster University in Canada, who's going to come and talk to us about the treatment of venous thromboembolism and the need for a real-world evidence base. Jeff.
These are my disclosures. So you've heard something already about the prevalence of this disorder. It's important to point out that it's a very common disease. There's about 1 to 2 cases per 1,000 persons in the general population, and the incidence increases with age. So for every decade over the age of 50, we have a doubling of the incidence of VTE. And it's also important to point out that in many patients, this is a chronic disease. They will have one episode of venous thromboembolism, and if you stop treatment, they will have a recurrence rate that is about 30% at 10 years. Now, what's the impact? Remember, the venous thromboembolism is a spectrum. It often starts as deep vein thrombosis, which is a clot in the deep veins of the leg. And what can happen is that part of the clot or the entire clot can break off and travel up and lodge in the lungs. And if it really blocks the lung arteries, that can be fatal. That's the pulmonary embolism. So in patients with pulmonary embolism, up to a quarter will present with sudden death. And this highlights the importance of us being aware of this disorder so that we can give good preventive therapy to prevent the deep vein thrombosis and the pulmonary embolism from happening in the first place. And of patients with pulmonary embolism who survive those first few hours, about 15 to 20% will die within 3 months. Sometimes it's not necessarily the pulmonary embolism that's the fatal event, but the fact that the pulmonary embolism is occurring in association with other medical conditions that can contribute to the demise. Now, in patients with deep vein thrombosis, up to 60% develop the post-thrombotic syndrome. So what is that post-thrombotic syndrome? They get a clot in the deep veins of the leg that doesn't open up, so they get obstruction to blood flow in the veins. And this means that as you're walking and standing, you get progressively more swelling in the lower extremity and more discomfort. And in some cases, as you heard, this can even lead to venous ulceration. So ulcers that form around the ankles and are very slow and difficult to heal. So post-thrombotic syndrome can be very disabling for patients because it limits their mobility, and they might have to use elastic stockings or compression bandages or even these compression devices to squeeze the fluid out of the lower extremities and make life more comfortable. Now, what about this recurrence rate in patients with venous thromboembolism? Up to 25% of venous thromboembolic events occur in patients who have a past history of a prior event. And in patients who get venous thromboembolism without an obvious risk factor, so it's not after surgery, for example, or in women in association with pregnancy or delivery, in those patients with unprovoked or sometimes called idiopathic venous thromboembolism, that's venous thromboembolism where we don't have an obvious cause for the event. The recurrence rate, if you stop blood thinning therapy, is about 10% at 1 year and 15 to 20% at 3 years, and even higher as you go longer. And the morbidity and the mortality increases with each of these recurrent events. So recurrent pulmonary embolism, you've had an event before, now you have another event, about a 15% mortality rate, and recurrent deep vein thrombosis, about a 2% mortality rate. So we've talked about the post-thrombotic syndrome, and even though we've had progress in diagnosis, in prevention, in treatment, we still see post-thrombotic syndrome in 20 to 60% of patients by about 2 years. And it has a substantial negative impact on quality of life, and there's a huge economic burden to care for patients, particularly those patients with non-healing ulcers. So, although this is a very common problem, we really haven't paid enough attention to making sure that we prevent that first episode of deep vein thrombosis, and if a patient does develop deep vein thrombosis, that we treat that disease aggressively to try and lower the risk of this devastating complication. Now, another long-term complication of the clot in the lung. So we've talked about post-thrombotic syndrome as being a long-term complication of clot in the leg. We said that you can have the clot in the leg travel to the lungs, lodge in the lung arteries. Most of the time, that clot dissolves over time, and the flow in the lung arteries is restored. But in some patients, in a small minority of patients, the clots don't dissolve, and the pulmonary arteries remain occluded with an organized clot. And this leads to a disease entity that we call chronic thromboembolic pulmonary hypertension. It's pulmonary hypertension because the pressure in the pulmonary artery increases, because you can imagine if the pulmonary artery is blocked with clot, the right side of the heart has to pump harder to get the blood into the lungs, and the pressure increases. And we really don't know how frequently this occurs because it isn't really looked at that carefully in most of our patients, and we probably underestimate how often this disorder happens. And it is really a devastating disorder because these patients are so short of breath that even if they were to walk to the back of that room, that would be a big ordeal for them, and some of them are short of breath at rest. So this is a really devastating complication, and treatment can involve drugs that open up the artery, but they may not work because the artery is blocked with clot. So then you have to go to surgery and really remount the blocked arteries, and that's only possible if the blockage is in the large arteries. If it goes into the smaller arteries, you just can't get down there to do it. So there are huge costs associated with this disorder, costs in morbidity and mortality, circulatory, respiratory related patient month costs are estimated at $2,500 per month. So what are the implications for therapy? It's really important that we do our best to prevent venous thromboembolism from the get-go. This means all patients at risk should be given vigorous thromboprophylaxis, whether they're surgical patients who are going in for surgical procedures or they're medical patients who are going to be relatively immobilized while in hospital for days or even longer. Once patients have a documented thromboembolic event, we have to make sure that we treat it appropriately. We give well-controlled blood thinning therapy, and we have to give it long enough that we allow the clot that's there to resolve, and we prevent the formation of new clots. And remember, we've said that there's a high risk of recurrent disease in these patients, so we must make sure that we give preventive therapy for as long as needed to lower the risk of recurrence, because every recurrent event not only increases the risk of morbidity, but also of mortality. And we're at a watershed moment in both the prevention and treatment of venous thromboembolism, because we have the recent introduction of a number of new oral anticoagulants. Right now, almost worldwide, rivaroxaban, an oral factor Xa inhibitor, is licensed for treatment of venous thromboembolism, and the apixaban and dabigatran are under consideration by licensing bodies for this indication. And we heard at this meeting the Hoxai data with edoxaban, and I'm sure it too will be in that queue for licensing. So we now have simple and effective methods to prevent and treat venous thromboembolism. So this is an ideal time to interrogate centers in numerous countries to determine what's happening now in terms of treatment of venous thromboembolism, and how will that evolve over a year or 2 years or 3 years as these new agents penetrate more and more into this VTE space. And with that, I'll stop, and I'll thank you very much for your attention.
Take a seat over here. If we may take questions at the end of the presentations. It's now my very great pleasure to invite Dr. Lorenzo Mantovani, who's also a member of the Garfield Steering Committee from the School of Medicine, the University of Naples, to talk not about the clinical burden of thromboembolism, but the economic and burdens of VTE.
Thank you, Professor Kakkar. Well, much of what I'm going to say is just a direct consequence of what you have already heard from previous speakers. These are my disclosure. Now, pulmonary embolism has a high fatality rate. This is a paper that has just been published. Last name is Samuel Goldhaber. This year on the American Journal of Medicine, and it actually reconfirms what has already been observed in studies, I guess, during the last 3 decades. When we assess cost, the easiest way to start with when you are dealing with acute events is start from the acute event. So the easiest, and to some extent initially the more meaningful way of measuring cost, is looking at the hospital cost. Now, this paper shows, apart from the healthcare burden, a cost, an average of patients with pulmonary embolism during the first episode of approximately $9,000 in the acute event. Preceding this, during the last decade, there has been a number of papers in which large administrative databases from US HMOs and payers have been interrogated and asked, okay, now we have the first event, the acute phase, then hopefully a number of patients will survive, and what is their cost, the management of this patient, for the next say 12 months. Now, 12 months is a convenient time period because it overlaps normally with a fiscal year. So managers are interested to know what will be the cost in their next fiscal year. These two papers, published in 2006 and 2007, actually investigated overall more than 40,000 patients with DVT, PE, both one before and the other one. I just want to highlight something from this. These patients have been identified by diagnostic code during a hospital admission. Look at their age. They are in the 60th decade. That means that a lot of these patients are still in their working age. Now, keep this information and we will come to back later on. What is the cost of managing these patients? Well, it depends on the disease they come to the hospital with the first disease. Pulmonary embolism is a little more costly compared to DVT. And we can say that on average, after the acute event, that patient will cost in the following 12 months, in the next year, between $11,000 and $17,000. Now, apply this to the epidemiology figures that you have heard or to the impressive numbers that you have seen in this database, and you know what would be the burden. Why is that burden beyond the first admission? It has already been said, because patients are at risk of a new admission. Now, a new admission is a risk for their health and is the risk for the healthcare budget as well, because readmissions are on average 50% more expensive than the first admission, and they are quite frequent. So the drivers of cost is hospital admission. Second and further hospital admissions are more costly than the first one, and they are quite frequent. This is for the US. For UK, this some years, it comes from an independent body of the NHS, the National Institute for Health and Clinical Excellence, and actually it's quite straightforward. They were estimating 25,000 annual deaths in England related to hospital-contracted VTE, which is more than breast cancer, HIV, AIDS, road traffic accident combined. And as we come to the economic burden, almost 650 million pounds per year, so an impressive cost. What can we do to avoid this cost? Now, first thing is prevention. This slide is quite basic, a little bit of history. It starts from a landmark paper of the late 80s, published on the JAMA by my friend Jerry Osser. They evaluated everything up to unfractionated heparins in major orthopedic surgery, which is, as you have already heard, a major risk factors. And everything that is effective, given that the burden is so high, everything that prevents that burden is either cost-effective or dominant. Unfractionated, low molecular weight heparins, top to the right, the paper on hematologica by Monia Marchetti of Pavia. And now lower, you see the Health Technology Agency. I have quoted NICE before, and I'm quoting the Scottish Medicine Consortium that someone calls the MEC-NICE. They have assessed drugs, oral anticoagulants, that are indicated in the prevention of VTE after a major orthopedic surgery, dabigatran, apixaban, rivaroxaban, and the three of them have been found again to be either cost-effective or dominant. Dominant means more effective and at the same time simultaneously less costly. The treatment. Well, once the patient has developed, we have to treat. Again, a paper on the Annals of Internal Medicine, Michael Gould, first name. Low moles, cost-effective, dominant, depending on the type of patient and the risk. Again, these are the two assessments by the Scottish Medicine Consortium based on the Einstein DVT and the Einstein PE trial. Again, dominance or cost-effectiveness for the factor Xa inhibitor, rivaroxaban. So what can we take home from this short review of what has been published in the last 30 years? VTEs are costly. They affect people in the working age to a great extent. Effective and safe prevention is also cost-effective or dominant, both in the prevention side and in the prevention of recurrences, so the treatment and prevention of recurrences. What's missing then? Now, all the evidence that I've showed you basically is based either on health economics model, decision analytic models, or on retrospective data analysis. What we are missing a couple of fundamental issues that we can only connect prospectively. Number one is the treatment variability and organizational issues around the care of this patient, because as new oral anticoagulants are available, the organization of care is likely to change, like it has been done and demonstrated in AF. And then we could measure what has become, especially in chronic disease. Now we come from ages of acute disease. A patient gets to the hospital, Florence Nightingale, he gets out dead, alive, healed, not healed, the acute phase. Now we are facing huge chronicity. Now when we are speaking about chronic disease, the outcomes are patient-related, what we call health-related quality of life or health status measurement. This is not in any systematic tool available in daily practice. We have to collect this on purpose, and we can only do that in a prospective study, which we will do with the GARFIELD-VTE. And so far we have spoken about healthcare cost, but we have missed, remember the age of this population, the indirect costs, the costs associated to mortality, morbidity, absence from work, and early retirement. These are issues that we will be able to measure with the GARFIELD-VTE. Thank you for your attention and patience.
It's now my pleasure to ask Professor Graham Turpie, again from McMaster University, to talk us through some of the insights from the GARFIELD Atrial Fibrillation Registry, which is ongoing with regard to arterial thrombosis management.
Well, thank you very much indeed. It's a pleasure to join you here in Amsterdam. As you've heard, thrombotic occlusion of arteries and veins is the commonest cause of morbidity and mortality that we have to deal with as clinicians. And I've heard about the importance of venous thromboembolism. Here are my disclosures. What I'm going to talk to you about is association of stroke and atrial fibrillation and the dramatic improvement that we have made in the last few years in preventing strokes associated with atrial fibrillation. I know that many of you have come across friends and relatives who've suffered a stroke, and you know the devastation that occurs, often with the requirement for long-term care, use of wheelchairs, paralysis of arms and legs. Often there's the problem of inability to speak. It's a devastating problem. But what we do know is that there are some causes of stroke where we can apply effective preventive medicine. And one of these is the risk of stroke in patients with atrial fibrillation. As you know, if you feel your pulse, you'll notice that it's regular, and it goes on millions of times in your lifetime. But as you get older, there's a possibility of disorders of heart rhythm. The commonest one is atrial fibrillation, where the beats are very irregular. One of the reasons for that is that the upper part of the heart, shown here in the top, the atrium, does not contract properly, and thus there is stagnation in that component of the heart. And stagnation is a very prominent stimulus to thrombosis. So you get a clot within that chamber of the heart, which, as you've heard from the discussion on venous thrombosis, can break off and travel, not in this instance to the heart itself, but out of the heart. And since the most direct route from the heart is to the brain, they commonly go to the brain, resulting in stroke. How often does this occur? Well, we've heard that stroke is responsible for 10% of deaths worldwide. And of these strokes, 30 to 40% are cardioembolic. They come from the heart. Half of these are associated with non-valvular atrial fibrillation. So an enormous number of people worldwide have strokes, and many, many of them are a result of atrial fibrillation. Now, since thrombosis is the key feature resulting in these strokes, it's not surprising that blood-thinning drugs, anticoagulants, might be beneficial. But surprisingly, it was not until the late 1980s that we had evidence that anticoagulants were helpful, when 5 randomized clinical trials demonstrated that the use of a vitamin K antagonist, largely warfarin, many of you know that drug as a proprietary rat poison, but is it a very effective pharmaceutical when administered in the proper doses, reduces the risk of stroke by between 60 and 70% in patients who have this irregular heartbeat. In addition to that, it reduces mortality by between 20 and 30%. So it has a very big impact on morbidity and mortality in patients with atrial fibrillation. Now, that's solid clinical trial evidence. And despite all of that and all of the education, we as a profession are not good at translating that information into practice. And if you look at the right-hand side of this graph, you can see the utilization of anticoagulant drugs in patients who should receive them based on all of the evidence and all of the risk stratification models that we use. About half of the people who should receive anticoagulants actually get them. Now, there are lots of reasons for this, and one, not the least, is that there's a perception in the community and in the medical community that warfarin has many limitations, and it does, although it is a very effective drug when used appropriately. But we now have the new anticoagulant drugs, which my colleague Jeff told you about, which are very effective and have much greater clinical utility than warfarin. Not the least is that they have a stable response. Everybody responds in the same way, and there's no requirement for the regular blood testing that is necessary with warfarin. These drugs have been tested in rigorous clinical trials and have demonstrated that they're at least as good as, if not better, than warfarin in reducing the risk of stroke. And very importantly, they reduce the risk of bleeding into the brain in comparison to warfarin. And to me, that's a very persuasive argument for using these drugs in most patients who have atrial fibrillation. Now, I did say that this is based on randomized clinical trial data. And that, of course, is very rigorous. And the big question that we have to address as doctors is, can we translate that information from the clinical trial into clinical practice? And this is what the registries that we are going to talk to you about do very well. And this started several years ago with the GARFIELD program out of the Thrombosis Research Institute in London, led by Professor Lord Kakkar. This will allow us to understand how well we have translated that clinical trial evidence into practice. It really is a very, very rigorous registry governed by the highest academic and ethical standards. And as I'll show you, it is somewhat unique in terms of methodology. You know, you can just look at your patients and see how well they do, and that is subject to much bias. But with the rigorous methodology of GARFIELD, we will be able to tell in a consistent way how well we are managing patients with atrial fibrillation. It's a novel approach to outcomes research, independent academic research initiatives, and it is worldwide, involving 34 countries, with randomized sites representative of the national average atrial fibrillation care, the sites were random in terms of their selection. And one of the very interesting features of this, instead of just looking at a single cohort of individuals with atrial fibrillation, we have 5 sequential cohorts almost on a yearly basis of 11,000 patients each. And that's unique because it allows us to determine how we're changing our management of patients with atrial fibrillation based on the introduction of new treatments such as the novel anticoagulant drugs. They are patients with newly diagnosed atrial fibrillation, so we'll be able to determine what happens to these people over a 5 or 6 year period because it's a prospective follow-up. They are representative of the care in the individual countries. We have a network of national coordinating investigators. The site list was selected according to the distribution of atrial fibrillation care in each country. For example, in this country here in the Netherlands, you have a very well-developed anticoagulation service where most patients are handled, whereas in Canada, in the rural areas, it's dealt with by family practitioners. In some major centres, such as Hamilton, led by Jeff, there is a very important thrombosis centre where much of the clinical trial evidence has been developed. Randomized site selection, as I mentioned to you. The patients who are included in this study are patients with atrial fibrillation over the age of 18 years. They have to give informed consent because we are making a lot of information put available to the public. Newly diagnosed non-valvular atrial fibrillation within 6 weeks of diagnosis, and at least one additional investigator-determined risk factor for stroke. Many people wonder, what is non-valvular atrial fibrillation? 50 or 60 years ago, one of the commonest associations of atrial fibrillation is rheumatic heart disease with massive destruction of the valves and often associated with atrial fibrillation. Now most of the atrial fibrillation is in the elderly population, and there's often degeneration of the valves, and we can detect some mild evidence of what we call mitral incompetence, regurgitation, that we would not call valvular atrial fibrillation, and these kinds of patients would be included in the trial. We didn't include people where we can't follow them up, and if the patients have transient atrial fibrillation due to a reversible cause. Sometimes, for example, patients with thyroid disease get atrial fibrillation, and when you treat the thyroid disease, atrial fibrillation gets better. Not very common. Now here we have the GARFIELD successful recruitment worldwide. As you can see here in cohort 1, we had individuals in virtually every continent apart from Antarctica, and we have now included additional countries in most of the continents with 24,000 patients already in the GARFIELD registry. Now here we are in the current phase of management of patients with atrial fibrillation. How interesting. I showed you the data 10 years ago, and we're no better. When we look at the utilization of anticoagulant therapy in the current era, there is no marked improvement in our utilization. But there's some bright spots. For example, the blue bar here is the use of warfarin. And you can see that based on the risk factors that the patients have, more doctors are giving the anticoagulants to the patients with the higher risk, which is a very important observation. But not enough. Only 57% of patients who have a score of 6 to 9 are getting anticoagulants. What is the risk of that individual having a stroke a year? 1 in 5. 1 in 5 people with that stroke risk will have a stroke in a year. And that's devastating. And yet, only about 60% of the people are getting appropriate treatment. We will be able to see how much better we do in the future with the introduction of new antithrombotic regimens, with much better education of the public and the medical profession by the ongoing registration or a register, the GARFIELD registry, when we have recruited what we plan to do, 55,000 people. So GARFIELD, the network, represents atrial fibrillation care as it is provided throughout individual healthcare systems. It describes the populations as a representative, and the treatment is representative, and we will know in the future what the outcomes are in these patients who receive or do not receive antithrombotic therapy. Thank you very much.
Well, Graham, thank you very much indeed for that. Now, what I'd like to do, as you've probably guessed, is to tell you a little bit about how we're going to try and understand patient outcomes for those in unselected environments, i.e. not the clinical trial environment, with venous thromboembolism. And what we propose to do, and indeed I'm able to say we're going to be able to do thanks to another unrestricted grant from Bayer Healthcare, is create a parallel registry to the AF registry for patients with venous thromboembolism. We propose to look at 10,000 patients with newly diagnosed venous thromboembolism from the time that they present acutely with their deep vein thrombosis or pulmonary embolism. And we're going to do this in, we hope, 25 countries, and look at both the acute outcomes for those patients and, most importantly, the long-term outcomes for those patients, both clinically and in terms of the way that healthcare resources are utilised. And as I've said, this is made possible through an unrestricted research grant from Bayer Healthcare. We have a global steering committee. You can see all the names here, very distinguished colleagues in the world of venous thromboembolism research and clinical practice from North America, Europe, Asia, and so on. We hope, all being well, to enter our first patient at the beginning of 2014 and to ensure that we have completed at least 3 years follow-up on the last patient. And this is quite important because most clinical trials follow patients for 6 months or 12 months. And we know little in large prospective evaluations about the outcomes of patients years after they first presented with their thrombosis. And there are some interesting things that we're going to be able to look at. Oh, sorry. There are interesting things that we hope to be able to look at. When we try and assess whether venous thromboembolism is being treated according to the many guidelines we have to help us in clinical practice, one of the questions we're still uncertain about is how long patients should receive therapy after their acute event in terms of providing the best protection against recurrent events. We are unclear about longer-term outcomes associated with the very early treatment of thrombosis and how that early treatment might have a longer-term consequence for the patients. We know little about the burden, the true burden of the late complications, as we heard from Professor Weitz, venous ulceration and pulmonary hypertension, and a prospective registry of all comers, patients consecutively presenting to sites with venous thromboembolism, provides a unique opportunity for us to do much more detailed evaluation of the late complications of venous thromboembolism. And we're going to be quite interested in understanding how practical it is for patients to adopt the new innovations and the benefits of the new guidelines for treating thromboembolic disease. And as Professor Mantovani has explained to us, there are important opportunities to study how healthcare resources are utilised in different healthcare systems and understand, therefore, the broader burden of venous thromboembolism. And also, and I think most importantly, evaluate patient-reported outcome measures so that we better understand the burden and the impact on our patients themselves in terms of what they experience, so that we can better improve the ways that we deliver clinical practice. And as I've said, we'll have 10,000 patients, probably in two cohorts, an early cohort of 5,000 and then a second cohort, so that we can use the same concepts as the Garfield AF programme in terms of looking at the temporal changes in clinical practice as new innovations in VTE management and anticoagulation become broadly available. Many different types of agents, as we heard from Professor Weitz, under development. Those will slowly be adopted in clinical practice. And by having two sequential cohorts, we'll better understand the differences over times in practice and see if those are associated with improved clinical outcomes, as might be suggested from the randomized clinical trials, but that we as clinicians would like assurance are actually attending patients in the real world as well as the world of clinical research. And as I've said, there'll be a number of endpoints. We'll be looking at deep vein thrombosis and pulmonary embolism recurrence. We'll be looking at the long-term consequences, post-thrombotic syndrome and pulmonary hypertension. We'll also be quite interested, and this hasn't been done to any great extent before, try and understand what happens in the other part of the circulation, the arterial circulation, when you're giving anticoagulants to treat patients who have presented with thrombosis in the venous circulation. But there's been some quite interesting research that says that thrombosis, venous and arterial, may be related to each other. There may be common factors that determine both. And the question has never really been addressed. If you're anticoagulating for one thrombosis, how do you impact the frequency and occurrence of the other thrombosis? And of course, most importantly, when we intervene in patients with an anticoagulant, we must always be absolutely certain that the small risk of bleeding complications associated with anticoagulation doesn't outweigh in any way the benefits in terms of longer-term exposure to an anticoagulant to prevent a recurrent thrombotic episode. And this type of research in consecutive patients presenting with a new thrombosis provides a unique opportunity to ensure that what we have seen in the clinical trials actually plays out in the real world with regard to the balance of risk and benefit for therapy. And then there are a variety of issues with regard to really understanding whether the persistent use of anticoagulation is associated with a substantial reduction in later complications, and understanding how that persistence plays out in the real world, where sometimes patients may be very encouraged to continue on their medication and other times they may give up. And that, with the quality of life assessment, will be important outcomes of this registry. As I've said, there will be 25 countries, and we will identify 500 representative sites in those countries to register 10,000 consecutive newly diagnosed patients, and the minimum follow-up period will be 3 years. And I think from the point of view of our patients and as clinicians, this type of research will help us identify and determine whether anticoagulation is really addressing the challenge of contemporary clinical practice. In that, are we addressing the needs of the highest risk populations where the disease is most prevalent and where the risk of recurrent disease is most substantial? Are we really achieving meaningful clinical outcomes for our patients? Reductions in the frequency of recurrent events, but also an important impact on reducing mortality associated with venous thromboembolism. Are we able to demonstrate that what we have shown in the clinical trials is actually achieved in the real world in terms of consistent safety? And are we certain that all the excitement we have about new anticoagulant drugs is again translated into the maximum utility for our patients, so they feel able to continue with treatment for as long as is necessary to achieve their best potential outcomes? Any questions? Graham, anything to add?
Things that's quite clear that we have to now pay attention to as health professionals is the cost. As we've heard, we have an expert on the panel, Lorenzo Mantovani. Sometimes I don't understand him, but he has got a very good handle on how these drugs will impact on costs, and I'd like to ask him, what's the simplest way of assessing cost of a new treatment?
Start measuring what happens before that something is introduced and what happens after that something is introduced. Having in mind one thing, or at least a couple of things. Now, for a healthcare manager, most of the times, a disease or a condition or a treatment exists only if it generates cost. So if it is costly, it's a problem. If it's not costly, it's not a problem. And that most of our healthcare systems tend to reason in terms of silo. That means just the drug budget, just the outpatient care budget, just the in-hospital budget. So this type of study has the unique opportunities to collect all this information in a single methodologically sound way and show, given that on one side you have maybe, as you have shown in AF, no treatment, or treatment with drugs that require monitoring, or treatment with drugs that require no monitoring or less frequent monitoring or different monitoring, to reconcile everything into a single chamber, I would say, a single room, and provide healthcare managers with information on where they lose, where they gain in terms of money. And that's the first thing. And we often discover in models, which is the second thing that we have to do, validate those models, that at the end of the day, you don't spend more, even if the drug costs much more. You spend more or less the same amount of money, but in prevention or in secondary prevention rather than acute treatment. And what you're left with is disease that you have prevented, virtually at no extra cost.
So one of the big advantages of the new anticoagulant drugs will be a shift from an in-hospital management strategy to a wholly outpatient treatment regimen. Will a study like this be able to identify what the advantages are in that setting?
Yes, it will be. And it will be able also to quantify other advantages for the population in terms of reduction of what economists call intangible cost, which has to do with quality of life, and indirect cost, which has to do with working capacity.
Graham, there's a question for you here. With reference to AF exclusion criteria, is paroxysmal AF also excluded?
That's a very interesting question, because paroxysmal atrial fibrillation means that it comes and goes, and there are obviously different types of paroxysms. Some can have an episode lasting a few seconds once a month, and we often don't identify that, but there are many patients who have symptomatic episodes, and all of the evidence so far suggests that these patients are at just as high a risk of cerebral embolism as patients who have permanent atrial fibrillation. So one of the tasks that we have is to be able to identify what these symptomatic episodes are, and if they are atrial fibrillation, and if the patients have the additional risk factors based on the scoring systems that we have put in place to identify those who should receive anticoagulants, then they should be treated in the same way as patients with permanent atrial fibrillation.
Okay, are there any further comments from the audience or questions? I'm going to, because we want to finish by 3:30, which is a couple of minutes. I just want to ask Dr. Weitz before we go off, what do you think are the biggest challenges that are going to face the translation of the exciting evidence from clinical trials with new anticoagulants in VTE treatment into having a broad impact across populations being treated for VTE outside the trial setting?
Well, I think in some countries it's going to be access to these new agents. They are more expensive on a cost per pill basis than warfarin, but there are a lot of savings, as you mentioned, that don't get counted when we talk about these silos. So I think one of the key barriers is going to be access to the drugs. And that's a barrier we're going to have to overcome because, as you saw from the presentations, this is a disorder that affects younger people. These are people who are very often working people who are making a great contribution to society. And if we commit them to conventional anticoagulation with warfarin, they often have to take time off of work to go and get their blood tested and time to have contact with physicians to get their dose adjusted. And that may not cost the healthcare system much, but it costs society a lot because it's time lost in contributions. And Lorenzo, are we going to be able to capture that part of?
Yeah, yes, we are going to be able to catch that. And on the scientific side, allow me to do this. The fact that there are going to be, in many countries, I live in Italy, and we have problems in access to this medication and other indication, it's going to be a kind of a natural experiment in which you can compare the before and the after in what we would call the where would population. That means where this patient diagnosed in 2013 rather than 2015, he would have received the treatment. So something like my friend Graham doesn't like, being able to match patients in different cohorts and have a kind of a natural experiment also on the cost and on the organizational issues around the care.
But access to these agents, at least in the atrial fibrillation space in Italy, for example, has been very, very slow.
Yeah, actually, I think that the bigatron has been approved a couple of months ago, reimbursed, and I think rivaroxaban a couple of days ago. So
you think it'll change?
Yeah,